Welcome to this explainer. Look, mastering EKGs isn't just some academic exercise you do for exams. It's a critical, life-saving skill. Out in the ER, rapidly recognizing a pathologic Q wave or a broad QRS literally dictates your immediate clinical action. So let's jump right in.
To get you ward ready, we're covering 4 key steps today. First, fundamentals of the Q and QRS. Second, identifying pathologic Q waves. Third, deciphering QRS complex abnormalities. And finally, a rapid clinical review framework.
Starting with Section 1, Fundamentals of the Q and QRS.
Okay, so what exactly is a normal Q wave? Basically, it represents that initial left-to-right septal depolarization. By definition, it's any negative deflection right before an R wave. You're typically going to see these as small, completely benign waves in your left-sided leads, so leads I, AVL, V5, and V6. Think of it as the healthy initial electrical spark crossing the septum before the main ventricles fire.
Now take a look at the timeline mapped out here. While that little Q wave marks the initial septal firing, the entire QRS width captures the full timeline of ventricular depolarization. In a healthy heart, this process is incredibly efficient, taking just 70 to 100 milliseconds. Really cement that tight timeline in your mind as your baseline, because the second it changes, you know you've got pathology.
Which brings us to Section 2, Identifying Pathologic Q Waves.
All right, here's your rapid-fire checklist for the wards. How do you know when a Q wave goes from being benign to dangerous? Well, a Q wave is considered pathologic, meaning it usually indicates a current or prior myocardial infarction if it hits these marks. Is it wider than 40 milliseconds? That's one small box on your EKG paper. Is it deeper than 2 millimeters? Is the Q wave greater than 25% of the total depth of the QRS complex? And finally, if you spot them in right-sided leads like V1 through V3, that is absolutely abnormal. These waves are essentially the electrical footprints of dead or dying myocardium.
Let's look at what those footprints actually look like in practice. Notice the dramatic depth on the left side, showing inferior Q waves from an acute inferior MI. Now compare that to the right side, showing anterior Q waves. Visual anchoring like this is crucial for spot diagnosing infarct territories on the fly. When you recognize these exact patterns, you instantly know which region of the heart is crying out for oxygen.
Moving on to Section 3, Deciphering QRS complex abnormalities. Let's break down narrow versus broad complexes.
We can actually split the QRS width into a really crucial dichotomy. Narrow complexes, meaning anything under 100 milliseconds, originate above the ventricles. They're supraventricular. On the flip side, broad complexes over 100 milliseconds originate in the ventricles, or they result from aberrant conduction, like a bundle branch block. Just glancing at that width instantly tells you exactly where the electrical misfire is located. Here's what a healthy baseline looks like. This perfectly illustrates a normal, narrow complex sinus rhythm. See those sharp, tight spikes? That means the electrical signal is efficiently utilizing the normal His-Purkinje pathway. It's zipping right through the heart's natural high-speed highway exactly as it should.
But contrast that with this broad, complex rhythm. This is ventricular tachycardia, and you can see the QRS is dangerously widened. Why is that? Well, it's because the electrical spread is much slower. It's moving cell to cell, completely outside of that normal high-speed conduction system. Make no mistake, this is a massive clinical red flag indicating your patient could be crashing right in front of you.
Now, beyond just the width, let me pimp you on a quick spot diagnosis question about voltage. What does it actually mean when the QRS complexes continuously alternate in their height, going up and down, beat to beat?
The answer is electrical alternates. This is a critical finding that happens when the heart is literally swinging back and forth inside a fluid-filled pericardial sac. If you ever see this alternating voltage on an EKG, you need to instantly think about a life-threatening massive pericardial effusion and prep for potential cardiac tamponade.
Let's tie it all together in Section 4, our Rapid Clinical Review Framework.
Think of this table as your ultimate rules of thumb matrix to keep in your pocket for your next on-call shift. Note how a truly broad QRS, so anything over 120 milliseconds, points straight to bundle branch blocks, hyperkalemia, or a ventricular rhythm. Meanwhile, if you see absent Q waves in leads V5 and V6, that strongly suggests a left bundle branch block. We also have to check the voltage. Low voltage might mean an effusion, whereas a high voltage QRS points toward left ventricular hypertrophy. Seriously, memorize these clinical associations. To wrap up,
Accurate EKG interpretation is what separates the novice from the expert. Next time you hold the 12 lead on a busy rotation, ask yourself, will you spot the subtle Q wave or broad QRS that saves your patient's life? Keep practicing and